Good morning. So today we will be discussing about two topics, that is high risk pregnancy and immunology of obstetrics. As such, high risk pregnancy requires a single class on its own, that's why we will be dealing in short about high risk pregnancy. So at the end of the class, a student should be able to know or define high risk pregnancy, then describe in brief about maternal mortality and near miss mortality in obstetrics. Enumerate various high risk factors and describe in brief about the screening for these high risk factors. Then some of the topics of high risk pregnancy factors will be discussed, and at the end the student should be able to describe in generally about the high risk pregnancy cases. So now coming to the definition of high risk pregnancy, it is defined as a pregnancy complicated by a disease or a disorder that may endanger the life or affect the health of the mother, the fetus or the newborn. So there are two factors for endangering the life, that is maternal mortality or perinatal mortality, and affect the health of the mother, that means the morbidity is also included in this. So all pregnancies, even the low risk pregnancies, are at potential risk as many a time. It may not be possible to accurately predict certain problems in labor, like prolonged labor and postpartum hemorrhage. Normalcy thus becomes a retrospective diagnosis. However, most of the time it is possible to assess whether a pregnancy is high risk or not beforehand, and this forms the basis of screening for high risk pregnancies. So about 20% of pregnancies are considered to be high risk, and that's why need special care. So they have a maximum maternal and perinatal mortality and morbidity. So since maternal mortality and death is considered as this thing because of the high risk factors, so maternal death as per the WHO is a death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of pregnancy, that is ectopic is also included in this, from any cause related to or aggravated by pregnancy or in the management, but not from accidental or incidental causes. That means suppose trauma or some condition which otherwise also the woman would have led to death of her. So these causes are not included in maternal death, and what we have defined earlier, all those causes are included in maternal death. So 20 to 25% of maternal deaths occur during pregnancy, and a major chunk, that is about 40 to 50% deaths, occur during labor and delivery. So we should be very careful during labor and delivery, irrespective of her antenatal period. And 25 to 40% death occur after childbirth, and it is more during the first 7 days of the period, that is in the perinatal period. So it is a global tragedy. So annually approximately 5,85,000 women die of pregnancy related complications, and major chunk of this, that is 99%, is in developing countries and 1% is in developed countries. So the causes of these you must have already been dealt when we were discussing maternal mortality, will be discussed separately, and even in community medicine also it must have been discussed. So maternal mortality globally from 2000 to 2017, it has declined by about 38%, from 342 deaths to 211 deaths per 1 lakh live births, according to UN interagency estimates. And India's maternal mortality ratio has seen a decline from 130 per 1 lakh live births in 2014 to 16 to 122 per 1 lakh live births in 2015-17. So it's a decline of approximately 6.2% was observed during this period. So initially the national target was given as 100, to achieve is 100 per 1 lakh by by year 2020, and some states have already achieved this figure. So that's why the Sustainable Development Goal target of maternal mortality ratio has been given now as less than 70 by the year 2030. So if we continue to apply various preventive measures, this figure can be reached in our country also. So there is another term which is called as near miss mortality. So this is defined as a severe life-threatening obstetric complications with an organ system dysfunction which does not result in her death either by chance or because of the hospital care that she receives during pregnancy, labor, or within 6 weeks after the termination of pregnancy or delivery. So it is very important to know about near miss mortality, because usually we take the figure of mortality only, but morbidity is usually forgotten. So that's why if the near miss mortality has to be taken into consideration. And this is a woman with at least one near miss event. So since we will not be able to deal it in detail, at least few of the facts of near miss mortality you should be aware of. So there is criteria for identification of these cases. So World Health Organization recommends 3 approaches to near miss mortality. One is the disease-specific criteria, then management or intervention-based criteria, and organ dysfunction-based criteria. Based on this, a woman is considered as a case of near miss mortality. So disease-specific criteria is severe preeclampsia, severe hemorrhage, either antenatally or postpartum hemorrhage, severe sepsis, and uterine rupture. What about management or intervention-based criteria? If the patient is admitted to ICU, or if patient undergoes obstetric hysterectomy, or she is given massive blood transfusion, or has been intubated or on ventilator. So these are the management criteria to consider a patient as a case of near miss mortality. And organ dysfunction based criteria are based upon apparent clinical diseases, then clinical markers and management needs. And the aim over here is to correct that organ dysfunction and arrest maternal morbidity to progress to maternal death. So that's why it is very important to care the patient for who are in near miss mortality, so that we can minimize maternal morbidity as well as maternal death. So most of the threatening obstetric complications which are seen, they can be predicted or prevented. So in majority of cases, we can take action much before the maternal morbidity or maternal death occurs. So that's why it is very important to know about what are the cases of high-risk pregnancy and which can lead to maternal morbidity or maternal mortality. So there are certain high-risk factors which are to be considered to include the woman as a case of high-risk pregnancy. One can be problems related to preconception, related to previous pregnancy, or during the present pregnancy. So problem related to preconception can be physical, like height, weight, etc., which we'll be coming to later. There can be social consideration for it, like low socioeconomic status, or patient is not getting the antenatal, is not taking folic acid before preconception, or her general health she is not looking after, and anemia has not been corrected before conception. Then problems related to the previous pregnancy, like low birth weight or large for gestational age baby, and then preterm labor or delivery, congenital malformations, previous cesareans or previous hysterotomy, previous myomectomy, then perinatal mortality or morbidity, then RH incompatibility, cases of previous abortion, previous case of post-maturity, then third stage accidents like postpartum hemorrhage or any other trauma to the genital organs, then medical disorders in pregnancy, which we'll be coming to later, then psychological changes and problems during labor like precipitate labor, prolonged labor, or obstructive labor. The problems during the present pregnancy include medical disorders and obstetric factors, which we'll be coming to later. Then intake of drugs exposure to radiation, then infection, then exposure to chemicals, and certain other complications we'll have to see to label the patient as a high risk category. So high risk factors include like physical factors. One is age at delivery, that is less than 19 years or more than 36 years. Short stature, weighing less than 145 centimeters. Weight less than 40 kg or more than or equal to 80 kilograms. Medical factors include anemia, hypertensive disorders of pregnancy, diabetes, cardiac disease, epilepsy, pulmonary diseases, particularly tuberculosis, renal disease, and thyroid disorders, psychiatric illnesses, viral hepatitis and other causes of jaundice, then infections during pregnancy. These are the high risk factors for during pregnancy, the medical factors. Then obstetric factors include recurrent abortion, ectopic pregnancy, antepartum hemorrhage, multiple pregnancy, which are common nowadays, abnormal presentations like breech, transversi, etc., polyhydramnios, oligohydramnios, elderly primigravida, grand multipara, teenage pregnancy, RH incompatibility, and previous cesarean section or any scar on the uterus, then hydatidiform mole, IUGR, and prolonged pregnancy. These are the various factors, high risk factors to be considered. So then, as we have seen that most of the maternal deaths occur during labor. So high risk labor, what are the various high risk labor points to be considered? They are preterm labor, postterm labor, previous cesarean section, fetopelvic disproportion. Nowadays it is mostly cephalopelvic disproportion. Then premature rupture of membranes or preterm premature rupture of membranes, prolonged labor, obstetric labor, shoulder dystocia, retained placenta, postpartum hemorrhage due to various causes, inversion of uterus, then perineal tear, especially 3rd and 4th degree perineal tears, and a rupture uterus, and unskilled attendant conducting their delivery. So screening for high risk cases. So it should start the initial antenatal examination, and preferably it should start in the first trimester. We should take proper history and all, all the relevant factors should be taken during the first antenatal visit. And this examination can be performed either in a big institution or in a peripheral center. Peripheral centers, they will screen the cases which have to be referred later to the higher centers depending on what are the risk factors and what is the gestation period of the patient. And some risk factors, they will not be evident during the first visit. They will appear later in the pregnancy. That's why repeated antenatal examinations are required. That's why they think, as advised, the patient has to come for regular antenatal visits. So again, the cases are to be reassessed near term, so that just before the delivery, so that proper consideration can be given whether the patient can deliver at a peripheral health center like PHC, or has to be referred to a tertiary care center. Then neonatals also are to be assessed very soon after delivery in high risk cases. That's why it is both the obstetrician and neonatologist are involved in this. So that's why it says the high risk cases should be delivered in the tertiary care centers where all the specialists and all the facilities are available. And not all high risk factors have show this degree. So the degree varies. That's why the initial doctor has to assess where it is best that the patient delivers. So like I said, initial screening history are the various factors which we had considered, physical factors like maternal age. Then the pregnancy is safest between the ages of 22 to 29 years and age less than 16 or more than 30 years, and pregnancy following a long period of infertility and following after induction of ovulation are high risk cases. Then the reproductive history like second and third pregnancies after a normal first delivery carries the lowest risk. And we should also consider the duration of labor and history of precipitated and prolonged labor. It's significant. And any injury to her newborn earlier, and what was the weight of the baby earlier. So these are to be taken into consideration to differentiate between a low risk and a high risk case. So risk approach for maternal child health care. We should identify high risk cases from a large group of antenatal mothers. This is more relevant in cases of peripheral areas. So during pregnancy, one should see whether there are various high risk factors to be seen which we have enumerated earlier. Some of the examples being elderly priming, short stature, if there is any threatened abortion, malpresentations, medical disorders, elderly grand multipara, then multiple pregnancy and bad obstetric history, previous cesareans, hydramnios or oligohydramnios, or any instrumental delivery is there. Then during labor, the factors to be considered are premature rupture of membranes, prolonged labor, any cord compound presentation, cord accidents like cord prolapse, retained placenta, postpartum hemorrhage, and puerperal pyrexia. So initial screening should be general physical examination, height, weight, BMI, high blood pressure, anemia, cardiac or pulmonary disease to be excluded, and orthopedic problems also to be excluded. So proper history, detailed history should be taken at initial examination, and general and systemic examination to be done in detail. Then obstetric examination is also relevant. That is right from the first visit, and especially relevant in third trimester. Various the presentation, position, and all, and fundal height to be taken properly. Then pelvic examination may have to be done in some cases, like uterine size, whether it is disproportionately small or big. Is there any genital prolapse? Are there any laceration or dilatation of the cervix? Whether there are any associated tumors or there is pelvic inadequacy, relevant especially in third trimester of pregnancy near the expected date of delivery. And course of the present pregnancy, how it goes. Cases should be properly assessed at each antenatal visit to detect any abnormality that might have arisen later, and importance should be given. Are there any investigations to be repeated besides those which were done at the initial visit? And any abnormality that might have arisen later should be considered in detail. So examples being preeclampsia, anemia, Rh isoimmunization, diabetes, fever, pyelonephritis, hemorrhage, large uterus or lack of uterine growth, post-maturity, any abnormal presentation, any history of exposure to drugs or radiation in between, and acute surgical problems. So complications of labor. Cases should be reassessed. That's why cases should be reassessed during late pregnancy and labor. Important points to be considered at that time are anemia, preeclampsia, eclampsia, then meconium stain liquor, malpresentations, malposition, fetopelvic disproportion, mainly it is cephalopelvic disproportion, preterm labor, PROM, and any abnormal fetal heart rate, then rupture, prolonged and obstructed labor, ruptured uterus, or any shock. So certain complications may arise during labor and place the mother or baby at a higher risk. So postpartum complications, sometimes an uneventful labor may suddenly turn into an abnormal one in the form of postpartum hemorrhage and other third stage complications like traumatic PPH. So that's why it's not that only during second stage of labor one should be careful. Even if everything goes on well, still third stage is also very important, because many problems even in low risk cases can develop during third stage. Then problems of to neonate also has to be evaluated, like Apgar score less than 7, hypoglycemia, anemia, low birth weight, any major congenital malformations, convulsions, infections, jaundice, respiratory distress syndrome, persistent cyanosis, hemorrhagic diathesis. Though it is in the purview of pediatrician, still at many places pediatrician may not be available or is due to some reason, and that's why an obstetrician should be aware of these problems also. So now we come to certain factors of high risk cases which will be dealing in brief because of the paucity of time. So elderly primigravida is one of these factors, and women having their first pregnancy at or above the age of 30. This age limit is arbitrary, and at some places the cutoff is taken as 35 years. Because nowadays many women are delivering at the age of 30 years and above. So, and at some places those who are above 35 years are labeled as mature primigravida. So outcome of pregnancy in these cases is adversely affected beyond the specified age and includes two group of patients, high fecundity and low fecundity. The high fecundity women married late but conceived soon after, and low fecundity women married early but conceived long after marriage. This group is more unfavorable as compared to the high fecundity patients. So in elderly primigravida, maternal complications can include increased incidence of miscarriage, chronic hypertension and other hypertensive disorders of pregnancy, abruptio placentae, uterine fibroid, ovarian cyst. Because of that, there can be certain complications. Then certain heart diseases, preterm labor, PROM, postpartum pregnancy, malpresentation, and multiple pregnancy. These are the various factors which our incidence is more, and that's why they have to be taken as, all of these cases to be taken as high risk cases. The intrapartum complications can be in form of prolonged labor, failed induction. In many of the cases it occurs. Then maternal and fetal distress, instrumental delivery, high cesarean section rate because of various complications, and retained placenta is commoner in these cases. Then postpartum, there is increased morbidity, and perinatal increased mortality rate, morbidity, increased incidence of low birth weight babies, and increased incidence of congenital malformations. So another age group that is the opposite of elderly primigravida is a teenage pregnancy. They are also liable for various complications. So pregnancy is occurring at a younger age, that is from the age of menarche to 19 years. And pregnancy can sometimes occur even when ovulated before the first menstrual period. So that's why before engaging in sexual practice, the teenagers must understand the reproductive physiology. So at this young age, their body itself is growing, and the need to support the growth of the fetus exposes them to additional physiological, physical, and emotional challenges. So the incidence of pregnancy, teenage pregnancy, is increasing day by day. In US, like they say, 11% of births were in teenage mothers, and around 80% of teen pregnancies are unplanned. That's why they become much more complicated. And 1/4 of teenage mothers have a second child within 2 years of their first birth. In India, early marriage is common, though it is illegal, and leading to a higher incidence which cannot be ascertained because many of these cases are not reported. But approximately it is said that 18 to 20% are teenage pregnancy in our country. And that's why we have to be careful in these cases. So there are various social risk factors in these cases. Poverty, early marriage, low academic interest and achievement, depression and stress, domestic or sexual violence can be there, limited job opportunities, social isolation, previous unplanned teenage pregnancy, single parent homes, maybe because of rape or incest, and then addiction and substance abuse and delinquency. So these are various social factors which lead to teenage pregnancy. So diagnosis, urine pregnancy test is required whenever a teenage girl reports to a doctor with a history of delayed or irregular periods of amenorrhea. This is essential for helping the teenager emotionally, physically, and medically. Early antenatal care in these cases is life-saving. Though many of the teenage pregnancies, they don't report in time. And if the early antenatal care is given, it prevents many of the adverse conditions. So what are the specific risks for these cases? One is very low hemoglobin, and chances of sexually transmitted infections are high. Then chances of miscarriage is high, prematurity, low birth weight babies, and hypertensive disorders are also there. Then increased cesarean section rate is mainly because the cephalopelvic disproportion, this is because the mother's pelvis is not fully developed in teenage girls. So management in these cases include antenatal period. One should monitor closely and prevent anemia, detect and control hypertension. Labor includes proper pelvic assessments, checking of the presentation and position, careful watch for progression of labor. And undue delay in progress should be viewed with concern in these cases, and also be vigilant against postpartum hemorrhage. And in postpartum cases, encourage lactation, and one has to give advice regarding contraception. That's important for subsequent pregnancies. So another high-risk factor is a grand multiparity, a pregnant mother who has had 4 or more viable births. An extreme grand multiparity, which is nowadays not seen that much, is defined as mothers having 10 or more previous viable pregnancies. About say half a century earlier, it was quite common, but nowadays it is declining. So magnitude of the problem, it constitutes 1/10 of the hospital population. Actually, rather it used to constitute, I would say, and account for 1/3 of maternal deaths in some developing countries. The complications, there is increased incidence of miscarriages, both spontaneous and induced. Then malpresentations due to associated pendulous abdomen and increased pelvic inclination with the deliveries and as the age increases. And antepartum hemorrhage is common. Then medical disorders like anemia, hypertensive disorder, cardiac diseases are exaggerated manifestations of hemorrhage and diabetes, varicose veins and diabetes mellitus. These are more common in these cases. And prematurity is also common in grand multipara. So it's a reflection of socioeconomic and environmental factors rather than the biological limits in these cases. And luckily nowadays grand multiparous women are, incidence is decreasing. So this was the social factors or physical factors which are there. There's a certain gestational condition will be taking in short, because these are the one class topics on themselves. So we'll be dealing only few of the high risk factors which are gestational conditions. Like one is hyperemesis gravitarum, in which there is a persistent severe vomiting leading to weight loss and dehydration occurring during pregnancy, and severe usually in the first pregnancy, and more is seen in twins, triplets, high-deformed mole, etc. And many of them have electrolyte imbalance. And possible causes include elevated levels of human chorionic gonadotrophin, elevated serum enzyme, serum amylase, and decreased gastric motility. So manifestation in the form of dry mouth, thirst, substantial weight loss, signs of starvation, dehydration, decreased skin turgor, fruity breath because of acidosis. And the treatment includes fluid management if there is electrolyte imbalance and patient is not able to take at all, and the antiemetics, and one should add multivitamins and potassium to correct electrolyte imbalance. And so these cases should be treated in hospital. Then hemorrhage in early pregnancy, the conditions include abortion, ectopic pregnancy, and molar pregnancies. I'll not be able to deal in detail about this. So abortion is expulsion or extraction from the uterus of an embryo or fetus before the age of viability, which can be spontaneous and induced, and it has already been dealt in detail when abortion was discussed. Ectopic pregnancy, that is implantation and development of fertilized ovum outside the normal endometrial cavity. And molar pregnancy, abnormal condition of the placenta with proliferative and degenerative changes in the chorionic villi. So all these conditions have already been dealt with. Then the antepartum hemorrhage includes placenta previa, which, as you all know, it's implantation in the lower uterine segment or near the cervix. The risk factors include multiparity, multiple pregnancy, previous uterine surgery, and then the manifest in form of painless, episodic, bright red bleeding without warning. And ultrasound is required for diagnosing this patient. And once it is diagnosed, one should not do any pelvic examination in cases of placenta previa, otherwise brisk hemorrhage will occur. And management depends upon the type, and LSCS is done in major degree of placenta previa. Abruptio placentae, which is separation of the placenta from the uterine wall in normally situated in location. And the fetal prognosis will depend upon the blood lost and the period of gestation. Risk factors include hypertension, preeclampsia, smoking, short umbilical cord, advanced maternal age, trauma, cocaine use, etc. Management, one has to assess the amount of blood loss and terminate depending upon the period of gestation and amount of blood loss. So the patient nearing term should be terminated. In other cases, one has to assess depending upon the general condition, amount of the blood loss, and the ultrasound findings. Abnormal amniotic fluid levels are also risk factors. It can be excessive, like polyhydramnios, where it can be risk factors can be macrosomia, hydrops, skeletal malformations, abnormal fetal movement, that is neurological abnormalities, obstruction of the GI tract, which prevents normal ingestion of the amniotic fluid, and spina bifida, anencephaly, hydrocephaly. Then in maternal risk factors includes maternal diabetes and RH ICU immunization. In management, most women of these polyhydramnios delivered healthy infants and no specific treatment is required. In very severe cases, excess amniotic fluid may have to be removed intermittently if through amniocentesis if it causes respiratory distress. Oligohydramnios, amniotic fluid less than 1000 ml, which could be highly concentrated, and if extreme cases of oligohydramnios interferes with the normal fetal development and reduces cushioning effect of the fluid around the fetus. And the causes can be failure of kidney development, obstruction in the urinary tract, IUGR, postpartum pregnancy, PROM, fetal anomalies, and poor placental function also can lead to oligohydramnios. So manifestation include fetal, facial, and skeletal deformities, pulmonary hyperplasia or IUGR, management frequent antepartum monitoring both clinically and by ultrasound, and Doppler studies also have to be done in these cases, and determine optimal time of delivery, whether extrauterine life will be better or we should carry on the pregnancy till a specific gestation. Then the antenatal corticosteroid have to be given if we have to terminate the pregnancy at early gestation. And hypertensive disorders of pregnancy is an important risk factors, in high-risk pregnancy. A high-risk risk factor include age, very low or higher, above 40 years, multiple pregnancy, PRIMIGRAVIDA, molar pregnancy, pre-existing hypertension, diabetes mellitus, renal or vascular disease, and prior history of preeclampsia or eclampsia. Then management depends on symptoms, and usually only delivery is the cure. So in mild preeclampsia, usually symptomatic treatment can be given, and then use of antihypertensive have not been proved useful in case of mild preeclampsia. Or severe preeclampsia management is important when has to be very careful about these cases. The definition you already know, and goal over here is to prevent convulsions and control blood pressure and terminate the pregnancy once a specific gestation is reached. Then the magnesium sulfate is to be used in these cases, and antihypertensives are important. Cardiac disease, impaired cardiac function, is mainly from the congenital or rheumatic heart disease. Goal over here is optimal uteroplacental transfusion, and proceed with pregnancy if disease is mild to moderate, and even in severe valvular damage, possible termination may have to be considered because there is a risk of maternal mortality, and correct valve lesions before pregnancy, and preconception planning is very important in cases of cardiac disease. So peripartum cardiomyopathy, though rare, it leads to many cases of maternal mortality, and symptoms include dyspnea, cough, orthopnea, and palpitation seen during last trimester of pregnancy and first 6 months of puerperium. And management to improve the cardiac performance, give anticoagulants during and after delivery, and cardiologists have to manage these cases. Urinary tract infection caused by Escherichia coli, Klebsiella proteus, and then asymptomatic bacteriuria is to be considered. Antibiotics, if left untreated, they can be lead to pyelonephritis and sometimes can affect the fetus also, resulting in preterm labor. So urinary tract infection should be dealt with properly. So high-risk cases, we're not considered many of these medical problems because of the paucity of time. And high-risk cases management also will be dealing in short. This high-risk cases should be identified and given proper antenatal, intranatal and neonatal care. And it's necessary that all expectant mothers are covered by the obstetric service of a particular area. And a doctor has to give a simple checklist for paramedical staff to follow to differentiate between low risk and high risk cases, and arrangement should be made for early examination of high risk cases by the medical officers. So health centers should have periodic specialist cover so that to differentiate whether this is a low risk or a high risk case and whether the referral to tertiary care center is required. And medical officers should frequently collaborate with specialists regarding these cases, and accordingly place of further management can be decided upon. So these are the various organizational aspects of management of antenatal cases in high-risk pregnancy. We have to strengthen the midwifery skills, proper training of residents and other paramedical staff should be given, should arrange periodic seminars, and concentration of cases in specialized centers should be there only of high-risk cases, and low-risk cases should be treated at peripheral places. And community participation is also important. Availability of perinatal laboratory even in remote places also should be considered. An improvement of literacy rate and health awareness of the community and economic status to be improved upon. Cases having a previous unsuccessful pregnancy should be seen and investigated before another conception occurs, so that we are ready for the subsequent pregnancy. And relevant investigation should be performed during that period, and investigations for hypertension, diabetes, renal disease and thyroid disorders should be done followed by proper treatment before next conception, and sexually transmitted infection should be treated before subsequent conception. So we end about the high-risk pregnancy. I know I have not gone into properly into all the aspects of this, but it's difficult to finish this in a half a class this thing. So individual cases have already been dealt in its various classes.